right, so like Tammy was saying, my name is Ken Bullwinkle. I'm the Inspira SCTU coordinator, and Mike and I kind of teamed up on doing the care of the transport of the cardiac patient. So Dr. Barzak talked a lot about the ECMO and that whole piece of it. We've done a few pre-ECMO transports here at Inspira, taking them up to Cooper during the COVID crisis as precursors to those patients that may or may not have been a candidate to go on ECMO. So kind of had a little bit of an idea what was going on.
Yeah, just to dovetail onto that, because of some teams are going out and bringing a perfusionist and a CT surgeon or critical care doc to directly cannulate the patients. But with our geography, we're not out in Montana with 3 or 4 hour, 5 hour transport. So that's mostly what we do as far as ECMO. It's a lot of retrievals to bring the patient back to Cooper for ECMO. We're not going out there and cannulating the patients, putting them on pump, and then bringing them back to Cooper.
So many of you do know what we do. A lot of you are 911 providers. I took a quick look at the participant list, and there's a pretty even mix between nursing and EMS. But there's also a decent mix of pre-hospital providers, true 911 pre-hospital providers, and then other ones know kind of what we do. But in our realm, both Mike's and my realm, our primary goal is to safely transport critically ill patients from a sending facility to a receiving facility, also known as interfacility transfers. And then there's also the element where we will respond to the scenes as well of an accident or an illness to intercept the patient from a ground team. In certain parts of the state, we're also being called to intercept STEMIs and intercept strokes, whether it's primarily on the air side than the ground. And then, of course, we have a wide variety of meds and treatments that we can utilize in order to stabilize the patient during the transfer. So Mike can talk about the configuration on the helicopter side.
Yeah, sure. We have an arrangement with Metro Aviation. The easiest way to explain it is Metro Aviation provides the aircraft and all the infrastructure to fly the aircraft. So they provide the pilots, they provide mechanics, the hangar space, and all the equipment that's needed. And Cooper, it's kind of a weird setup, but Cooper 1, which is down south, it's located in Cumberland County in Millville. The nurse comes from Cooper, and it's an Inspira paramedic Inspira provides the flight paramedic. At Cooper 2, which is located in Burlington County, it's all Cooper employees except for the pilot. So it's a registered nurse and a paramedic from Cooper. And sometimes we bounce back and forth between the two bases, but generally down south in Cumberland County, Inspira does staff the paramedics for the helicopter. And Ken will talk about the Inspira transport side because they transport a ton of patients to Cooper.
Yes, and we have a different types of makeup depending upon our crew configuration, and it really a lot of it has to do with staffing, and a lot of it also has to do with the capability of the crew. So we have either an RN EMT and an EMT or a paramedic as the second person. We have a paramedic or an RN MICN, which has the ability of being what we call a triple license truck, which means we can do BLS, ALS, 911, as well as interfacility or SCTU. Or what we're hoping to be able to get to at some point is a true SCTU model, which would be an EMT, a paramedic, and an RN or an RN MICN, which would allow us to have 2 ALS providers in the back of the truck to be able to manage the critically ill patients. It's much like the configuration in the helicopter where the pilot, takes care of the nurse and the paramedic, as well as the EMT would then drive the paramedic and the nurse taking care of that patient. So trying to dovetail the two, because when the weather is bad and when the weather has issues, then we need to then have a ground transport team that can do the same and have the same capabilities. So we're almost there, but we're getting there. So what do we transport? And this is kind of one of those things where I think a lot of people are not sure all what we do. So Mike will go through this part of it with you.
There's very few that we can't transport. We transport everything from, hey, can you hop on the stretcher and we'll take you to the hospital, to I think I've taken a patient that was on 14 drips before and was on a balloon pump. So there's all sorts of stuff we can take. Weather and weight are really the big limiting factors. Obviously, we can't fly a patient if the weather's dangerous. And, based on crew configuration, there's different weights we can take. And also not just the weight, but the patient girth also plays a role, because sometimes we can accommodate the weight, but if they're 4x4, we can't fit them in the aircraft. But we will pretty much come and check out everything to see if we can transport it. So as far as what we transport cardiac wise, one of our bread and butter flights are STEMIs. We go to smaller community hospitals that don't have an interventional cath lab or don't have interventional cath available 24/7, and bring them back to Cooper. And we will provide any care that was initiated at the referring facility. Also, if we encounter a STEMI patient in the field, like if we have a scene flight, we'll do the standard O2, aspirin, nitro, pain control, and also treat cardiogenic shock if we need to. I just mentioned cardiogenic shock. We have a full array of medications, just like you would see in the ICUs. We can take anything that your patient is on. And also we have a ventilator that does invasive, non-invasive. So we can put them on BiPAP, provide them with PEEP, and work to reduce the patient's preload. Aortic dissections are some of the more tenuous patients that we transport. These are ones that kind of, test the metal, because these patients are so critical. But we transport a fair number of these patients, and obviously our goal is to treat the heart rate and to treat their hypertension to keep them stable. And we accomplish that in our protocols with Esmol and nicardipine. Balloon pumps. We've been taking balloon pumps for years. These are a bridge to surgical repair. So a lot of times what happens is someone will come in with a STEMI, or they'll come in for a elective cath. The interventional cardiologist will go in, see that the patient has severe triple vessel disease, and realize that, stenting's not going to cut it for this patient. So oftentimes they'll put the patient on a balloon pump, which provides counter pulsation, and that reduces myocardial oxygen demand and supplements the cardiac output. And that's a bridge to surgery. So this sometimes happens at some of these referring cath labs that we go pick patients up from, and we can definitely take a patient on a balloon pump. We'll monitor the pump. We'll keep them on max augmentation. We'll monitor the timing, and sometimes it takes a little bit longer to transport these patients because we have to reconfigure the aircraft to fit the balloon pump, and we have to insert a bracket. So sometimes it does take a little longer to get to these patients, but we definitely can transport these patients. Same thing with Impella. We're seeing more and more Impella as the technology improves. And we can transport a patient on Impella. Again, we're not really making tweaks to the Impella therapy. We're just kind of transporting them as they're found. We'll maintain them on the settings at the referring facility. But if something does go awry, we have protocols in place to intervene and to safely transport the patient that decompensates that's on an Impella. And I think we talked about ECMO, so I'm not going to go into too much depth with it. Right now, air transport is not transporting ECMO, but like I said, our geography is kind of advantageous to us and to the patients, is we can just go quickly pick them up and bring them to Cooper where they can be cannulated, as opposed to if you were out in the middle of nowhere, out west, where you would have to fly a team out to cannulate the patient.
And like I said earlier, we had taken a fair amount of our patients during the whole COVID crisis from the Inspira facilities, and we've taken them to Cooper specifically for ECMO. So they don't quite look like this when we've transported them, but they're usually on, decent amount of pressors. They're on a decent amount of circulatory support as well as ventilatory support, and they're getting cannulated up at Cooper.
And transport teams across the country do take ECMOs, and I just wanted to highlight for any EMS providers out there, or anybody that's curious, or if you were interested in doing critical care transport, we're not managing the ECMO because we're not trained on the ECMO. We bring a perfusionist. We would bring a perfusionist with us to manage the ECMO circuit. So the role of the critical care transport team is to treat the patient just how you would treat the patient. If they need to titrate their pressors, you'd go up on their pressors. If you need to code the patient, you would work with the perfusionist, but you would administer code drugs as needed. So you treat the patient exactly the same as any other patient, and the perfusionist would manage the ECMO circuit.
So one of the things that determines the method of transport, and this is always a question that comes up for various things, is weather. Mike alluded to the fact that the weather is certainly a factor for air transport, which is one of the reasons why it's important to have that dovetail relationship between an air program and a ground transport, because we can provide that same level of transfer care when the weather happens to be bad. Distance is also a determining factor sometimes, and the sense of urgency. And I have the sense of urgency in quotes here because there's always a sense of urgency when you move a patient from point A to point B. But it's just the level of comfort that the physician has with that patient being outside of that environment. Because if you think about it, we're taking somebody from a potentially unstable patient in a reasonably controlled environment, putting them on wheels in one way, shape, or form, and putting them into an uncontrolled environment, and with that same instability, and then trying to deliver them to another controlled environment. A lot can obviously go wrong. So some physicians feel a little bit more comfortable with sending them by air if that's a possibility. But again, when you look at distance and weather and look at a bunch of other factors, it may or may not be the best mode of transport. Some physicians have their own personal preference. They would prefer the air team versus the ground, and we respect that. And any of the care needs of the patient during the transport are also equally important, because is there modalities that one versus the other can handle? And there's very little difference in the capabilities, but where there's a lot of difference is the comfort level of the sending and receiving facilities and the comfort level of the crew. Mike alluded to the size of a patient is also a determining factor, and there'll be some photos coming up that will show you some of the size limitations, both in girth and in overall size of a patient, that contribute to this. Certainly the amount of equipment that's needed during the transfer is also a consideration, and whether or not there's a specialty team needed. So as Mike said, we're taking a perfusionist for ECMO, but I have a picture up here on the screen of a former colleague or former program that I worked for. We transported a lot of isolettes. And it's to give you an idea of the size of the isolette and the sled that went into the back of the helicopter. It takes up a fair amount of room, and it also adds a significant amount of weight to the aircraft. So in this case, that sled weighed 300 pounds. So that was 300 less usable pounds that we had for the flight side. Now, obviously on the ground, we don't have the weight considerations, because our stretchers can handle 750 pounds. And we're fortunate that we have 2 units that are constituting a bariatric unit. So we can take patients that are, 600, 700, 800 pounds or more using lifts, ramps, and other specialized equipment specifically for that population.
I just saw on here that there's 2 questions. I'm sorry, I haven't really used this program much. Actually, we have a couple of questions. Robin, Zach, Tracy, Brandon, Tana, I'm sure I'm saying that wrong, and Kelsey. So how do you go about asking these questions? I know there's a Q&A chat field.
Yeah, I can't see that actually. There's the Q&A.
I'm trying to pull them up. I don't see nothing came up in chat or Q&A.
It's under attendees.
They asked a question under attendees, Mike?
Yes.
Yeah, I see the bubble, but I don't see any information in it.
Yeah. Okay. No worries. I just didn't want to pass over anyone that
I'll
had.
keep looking.
Yeah, I guess if anybody in the
Then put it in the chat, please, and we'll get it answered.
definitely.
That's fine. I think there were some old questions.
Okay.
An example, Greg Brown brought this up. If you look outside today, today's weather is playing a little bit of a challenge too. So, Mike, do you want to talk about the air transfer needs?
Yeah, there are. So what happens is when a referring facility requests or a 911 center requests air transport for a patient, we get the request, and the first thing the pilot does is they check the weather. And the pilot determines based on our minimums that you can see up there. And it's not just minimums. We may meet minimums, but the pilot may not be comfortable with where the weather's going. They may say, right now we meet the minimums, but in 25 minutes, I can't guarantee that we're not going to have to land in a marsh somewhere with the patient because it's not safe to fly. So the pilot will determine whether we can do the flight based on weather. And one thing that I don't think a lot of people know is that when we are requested, we don't know what we're going for. And that is on purpose. That's because they want us to make the determination of whether we accept the air transport strictly based on safety and whether we can facilitate the transport or not. In the past, there have been crashes because crews have known what they were going for and made a determination based on oh my God, well, it was a kid that was hit by the car. It's cloudy out and it's supposed to storm, but, I think we can help this kid out. And they end up hitting weather and crashing. So they don't tell us what we're going for until we accept the flight. Once we say, yes, it's safe for us to go, then they'll tell us what we're going for. Weight and balance, every shift, we get a briefing from the pilot and we have to give them our current weight or the best that we know it. And it's kind of a, no pun intended, a gut punch sometime to every day cough your weight up to the pilot. And they'll do what's called a weight and balance form and figure out how much weight they can take if, we're called to transport a patient. And usually we can take patients that are pretty large. It does happen, but it's definitely the exception rather than the norm that we have to decline a flight for patient weight. And even if we're on the fence, if they tell us the patient's 1,200 pounds, then obviously, which we have gotten requests like that before, we're not going to be able to do it. But if it is one of those, well, I don't know if we can do it, maybe we could, we will fly down and check the patient out to see if we can do it. We're just not going to straight up say, oh no, too big, can't do it, unless it's, out of control. But, we'll come down and check out the patient. And one of the reasons is, and I mentioned it before, it's the girth. Ken and I took some pictures of the aircraft, and you'll be able to see that, if your height while laying on the stretcher is too high, we're not going to be able to get you into the aircraft. And that kind of kills the transport right there. So then they would have to go by ground. That's our helicopter. It's beautiful. It's an EC-135 for any aviation nerds out there. And as you can see, there is the landing area, or not the loading area for the aircraft. You can see we have another picture with a tape measure to show. Yes. And this is there's not much clearance to put the patients in. Even I worked last night, we transported a very skinny guy, and we still had to lie him completely flat to get him in the aircraft. So and is there another? Okay, I wanted to go to the patient compartment. Yeah, that's all our pumps and our vents. We have everything mounted down. Everything's got to be FAA approved to safely mount. We can't have anything free floating. Like we can't put the monitor on a chair or, sitting on the floor. Everything's got to be mounted appropriately. And this is big time infrastructure. Aviation equipment is kind of like tactical equipment. If you tag the terms tactical or aviation onto a piece of equipment, you can add a couple thousand percentage points to the price. So this is big time infrastructure, and this is a huge investment that Metro and Cooper and Inspira have made. This is a probably the worst picture of me that has ever been taken, but I wanted this picture to show how tight it is inside the patient compartment. And that bag that you see sitting on the stretcher, obviously the patient's going to be on the stretcher, so the bag's not going to be there. So the bag will be in an extra seat, or it'll be bolted down to the ground, literally bolted down to the ground and strapped down. So one of the things we encounter in air transport, not often, but it does happen, is we go to a referring facility and you may have somebody that's like, just get them out of here, get them on your stretcher and get them the heck out of my facility. And we take the time, we do have time benchmarks so that we don't dally, but we want to take the time to stabilize the patient as best as we can before we put them in this aircraft, because just because of size and the movement, it's very difficult to manage a crashing patient just because you're so confined in this little airspace. So if we can do something like titrate a pressor or start a new medication, or draw an ABG and try some vent settings, we're going to do that at the bedside to make sure that the patient is stable enough for transport. Because we also know, anybody with critical care experience knows that there are those patients that are so critical that simply moving them from stretcher to stretcher will cause them to decompensate and sometimes code. So that's our space. That's our home. That's our ICU and our ED. And Ken, do you have anything to add?
No, it's very challenging to work in the back of that environment. Having spent 5 years in that environment, going to where I am now, with having the larger ambulance, which you're going to see the difference in just a moment, makes a world of difference. But one of the pieces that's really important to worry about for anybody, especially those in the hospital, is that there's a rhyme and a reason why we hook things up the way that we do and how we handle everything. Because as you see, at least with the picture that's up on the screen now, all of these pumps, they may all be running, and then they have to be removed off of the patient and mounted to the rail. The ventilator needs to come off of the patient and off the stretcher and secured to the side rail there. And the same thing happens with us on the SCT, is we have our monitors mounted. We have our pumps that have the clips to be mounted in a certain way. Then when we add in the ventilator and add in a bunch of other pieces of equipment, it can be rather challenging. And the difference between air and ground transport is we don't have the spinny rotors. So we don't have the downdraft. We don't have the chance of things being, sucked up into the rotors that potentially can cause a problem. But everything needs to be packaged appropriately. So those ICU nurses that may be out there kind of understand what I mean about every tube has to have a spot to go and everything has to be reasonably neat. So when we package up a patient, both on the ground and in the air, it's all in the effort of, once we get into whatever rig we happen to be, whether it's the aircraft or the ground transport unit, and then we have to undo everything to secure it properly for the air flight or for ground transport. So then we have to then package it all back up again and then take the patient out of that environment as well. So there's multiple
in a way that all the 10 drips don't look like Clark Griswold's Christmas lights.
Yeah, it's never good. It's never good rolling into a unit that way.
Yeah.
So switching modes from the aircraft to the ground transport unit, everybody's seen an ambulance. At least most of you, I think, have seen an ambulance. And this is a copy or a picture of our fleet that we have within our Millville station. All of our SCTUs are in these box ambulances that allow us to have a maximum amount of space within inside of them. This is one of our setups, from one of the most common setups that we have. And you can see we have the Stryker power load stretchers. So because of our commitment to the safety of our crew, all of our SCTU units, they not just have power stretchers, but they also have power loads, which decrease the amount of lifting involved especially for some of those heavier patients. But as you can see, there's obviously a lot more room than the helicopter, but there's still not a ton of room. And then most of our stretchers have that arm to mount the monitor. And as you can see in the right picture there, we also have our pumps that are attached to the top of the monitor. Now, every one of our nurses does things a little bit differently about where they like their pumps and where they like their drips, but they're all reasonably within arm's length of the bench seat on the side. So like I said, we do have more room, but not a ton of more room. We have less room in here than you do in a typical ICU. Just another kind of a view of the bench seat on the side, and we're seat belted in for the most part at this point. So everything has to be within our reach in order to be able to care properly for that patient. Like I said, this is a standard configuration with a full bench seat on the side. We have some of our newer ambulances that have these two bench seats or captain seats on the right-hand side that have a mount for our tablet for our documentation. So we lose that bench seat, so it gets a little bit tighter in there. And of course, then we have to be a little bit more creative with where we mount our monitors and our pumps and so on. Much like the unflattering picture of Mike that we took, and I'm really sorry for that, we have about the same amount of room at the head of the patient as they do in the aircraft, except we have the benefit of this open area on the side where we can secure some additional bags and pieces of equipment as we go forward. So with either modality, it doesn't matter which one we're talking about, we essentially do the same thing. And it's the crew configuration that makes the slightest bit of a difference. But our primary goal is that safe transport from point A to point B. So information that is incredibly important for us is the same. We need to know what the weight of the patient is. We need to know what medications or drips that the patients are on. We need to know kind of a working diagnosis. Now, we're fortunate on the ground that we definitely will get a lot of this information ahead of time, but it may be kind of sketchy. So sometimes our crews will call ahead and ask for a report. But one of the things I want you to understand is that does not replace the report that should be getting at the bedside. And we get a lot of pushback from the nurses. And we get a lot of pushback from the sending facilities at times where they say, hey, we didn't know you were coming, or nobody said you were on your way, or they didn't give me an ETA. So if I can impart any piece of advice on transport that in any fashion, is when you know your patient is being transported, anticipate us getting there fairly quickly. Because if everything works the way it's supposed to, we should be there within a reasonable amount of time. So even if you haven't been fully told, hey, it's 20 minutes, or hey, we'll be there in a half an hour, anticipate the fact that you need to finish up your charting, your medications, get that chart finalized, because the air transport will be there in a relatively short amount of time. And we might be driving past the facility and be rerouted to your case or your transfer that may only be a 5-minute wait or 10-minute wait. So it's important to anticipate the fact that we know you want your patient out of there. We know that the best thing is to get the patient to the receiving facility. And regardless of whether we're talking air or ground transport, we're going to do our best to make that happen as quickly as we can. So kind of anticipate that. Our next slide that we have here, these are memes that have been floating around the internet for quite some time. The picture on the left is actually a legitimate transfer, but it's from the military. Obviously, that's in a C-17 military airplane. But it's designed to just show you the fact that this is what we do. We can do this. Now, if you call on Spirit SCTU and say, this is the type of patient that you have, we're going to be sending multiple crews to assist with this because there's a lot to do, a lot to move around, a lot to get transferred over. And this will be a very calculated process between a number of people. And then the meme on the right is just simply one of those things like, ICU nurses are looking at them, 1 or 2 drips, patient stable, just come here and drive fast. Well, this is a frequent patient that Mike and I and our team will encounter. And one of the things I used to say to people all the time, the more drips, the more cannulas, the more things that I had to deal with on a transport, the better off I like the patient, because it allows you to think and allows you to really utilize your knowledge and your background to be able to safely transport our patients.